morning. My name is Marie Wolf, and today we're going to talk about a tonsil and adenoidectomy.
Tonsillectomy is a surgical removal of the tonsils. A tonsillectomy used to be treated infection and inflammation of the tonsils. Today, a tonsillectomy is usually performed for sleep-disordered breathing, but still may be a treatment when tonsillitis occurs frequently or doesn't respond to other treatments. An adenoidectomy is actual removal of the adenoids. They are usually removed at the exact same time that the tonsils are removed. The oral cavity is compromised of the mouth and salivary glands. The mouth is formed by the cheeks, the hard palate, the mandible, and the tongue. It extends from the lips to the junction of the hard and soft palates. The portion of the mouth outside the teeth is the buccal cavity, and that on the inner side of the teeth is the lingual cavity. The salivary glands consist of three paired glands, the sublingual, the submandibular, and the parotid glands. Tonsils are masses of lymphoid tissue. The tonsils form a protecting circle in the back of the throat. They guard against pathogens entering the body through the nose or throat. There are three different sets of tonsils. The first set is the pharyngeal tonsils, or the adenoids. The adenoids sit behind your nose above the roof of your mouth in the nasopharynx. Air passes over these glands when you take a breath. The adenoids are often taken out the exact same time as the tonsils. The second set is the palatine tonsils, which lies in the posterior of the oral cavity. Lastly, there are numerous lingual tonsils, which are concentrated in patches on each side of the base of the tongue. Many different reasons why someone's going to have their tonsils removed. The first one is a person has tonsillitis that does not get better or that it comes back very often. A person has strep throat that keeps coming back within a year, even with antibiotic treatment. Abscesses of the tonsils is another biggie. If they don't get better after they are drained, or the person has an abscess along with other signs that point to a tonsillectomy that needs to be done. A foul odor or taste in the mouth is usually caused by tonsillitis, and it doesn't get better with antibiotics. Sometimes a biopsy is going to be needed to check for a suspected tumor of the tonsil, especially if the patient is going to be older. If the tonsils are way too large, that they affect nighttime breathing. This is called sleep apnea. This often most affects children, especially at a young age. So the first thing that's going to be done is you're going to call your physician and set up a doctor's appointment. And the first thing that they're going to do is they're actually going to just do a physical exam on you and see if they can diagnose the issue. Good afternoon, Michael. What seems to bring you to see me in today?
Well, I have had this nasty cough and sore throat for about 5 days now. It hurts to eat and talk and swallow.
All right, well, let's take a look. You can see poor Michael's tonsils are red and swollen. They are a grade 4 on a scale of 1 to 4, 4 being extremely severe. They're touching in the middle. There are pus patches on them. He's having a hard time swallowing. He has a scratchy voice. We need to do further testing to see what's causing this tonsillitis and to see if it's severe enough to actually have them removed. Further testing is going to consist of the doctor palpating the neck, checking for swollen lymph nodes, which can be an indication of infection. The doctor will rub a sterile swab over the back of the throat to get a sample of secretions, which will be tested for streptococcal bacteria. A CBC will be run to check red blood cells, white blood cells, and platelet levels. If the platelet count is too low, the procedures will be canceled. Bleeding after surgery can be a major complication, so they want to make sure the platelet count is at the appropriate level.
After reviewing Michael's record, this is the 6th time this year that he's came in with strep throat. I think it's time he actually has to have them taken out.
Equipment needed will be a donut headrest, shoulder roll, suction, ESU, fiber optic headlight, sitting stools, fiber optic light source, and RF co-blader generator. Supplies needed will be medicine cups, lidocaine with 1% epi, control finger syringes, basin set, suction tubing, red Robinson catheters, and tonsil sponges. Instrumentation needed will be tonsil and adenoid tray with mouth gags, usually the Crow Davis, ESU suction, and RF coblation probe and cord. The patient will be placed in the supine position with the neck extended and their arms may or may not be tucked. The patient will be intubated and administered general anesthesia for the procedure. If the patient is older, then lidocaine with epi may be administered as well. The skin prep will not be used for this particular procedure. The patient may be draped or not. It depends on the surgeon's preference. If they are to be draped, a sheet is placed over the patient's body. The Crow Davis mouth gag is inserted with the appropriate tongue blade and attached to roll towels or the Mayo stand. The tonsil is retracted medially with a curved Alice. The coablation handpiece is used to dissect the tonsil away from the underlying muscle and tonsillar fossa following the plane of the tonsillar capsule, while continuing to retract the tonsil immediately with the Alice clamp. The final attachment of the inferior portion of the pharyngeal tonsil to the lingual tonsil is transected with the coablator. The procedure is repeated to the other side. Coablation causes shrinking of tonsillar tissue using low-level heat from radiofrequency energy. Great care is taken during the intraoperative suctioning not to dislodge the endotracheal tube while preventing blood from being aspirated or from entering the stomach. The tip of a 12-French red rubber catheter is advanced through one of the nares into the nasopharynx and out through the mouth. The catheter is gently stretched and the two ends are clamped snugly with the Kelly clamp near the upper lip to retract the soft palate forward. The adenoids are visualized with the laryngeal mirror and removed under direct visualization using the coablator. After the tissue has been removed, the oral cavity and nasopharynx are irrigated and monitored for bleeding. Always keep your setup sterile and yourself until the patient has completely rolled out of the room and headed to the PACU. Let's talk about why for a hot second. As the patient is waking up, they tend to cough. If they cough hard enough, they can dislodge a clot and start bleeding pretty quickly. By staying sterile, you're able to pull right back up to the patient and aid in hemostasis with the surgeon. Now let's talk about specimens. First, it's going to depend on the facility's protocol regarding tonsils and adenoids. However, at Carilion, if the patient is under the age of 18, the tonsils are considered trash unless the surgeon requests otherwise. If the patient is 18 or older, the tonsils are sent to pathology to look for any abnormalities in the tissue. Here's why. 97% of the time a patient is going to have their tonsils removed, it is done at an early age. This procedure is considered clean contaminated.